Good evening, all. I am Dr. Anusha, Assistant Professor in Kamineni Academy of Medical Sciences and Research Center. Today, I am here here. Today, I am here to welcome you all for the ISA National PG online classes. Today's the topic of discussion is about regional anesthesia and anticoagulants. Before proceeding to the discussion, let us invoke blessings from Ma Saraswati. Now I request our Honorary Secretary, ISA Nation. Now I request our Honorary Secretary, ISA National, Dr. Sukhmender Bajwa, sir, to address the audience. Welcome, sir.
Yeah, thank you, Dr. Anu. I welcome the team of Dr. Varesham sir and his institution. That they are going to touch upon the topic which is very relevant in everyday's practice, teaching, as well as for the theoretical and practical purposes. The regional anesthesia and the patient on anticoagulants. After the age of 40 years, I think almost every fifth person is on anticoagulants, and you are invariably facing, especially the postgraduate in second and third year when you are doing the pre-anesthetic checkup, these patient comings to you in the pre-anesthetic clinics. And there you are always in dilemma what to do, whether to go for the anesthesia and surgery, when to stop, for how many days to stop, is it going to continue, how to weigh the pros and risks, cons and pros and cons for especially the patients who had a cardiac surgery or are going to undergo some procedure, or already, on a different comorbidities, also combining the problems for the pre-anesthetic evaluation. Also, in the perioperative period is a very, very stormy period sometime with the patients on anticoagulants. So a lot of myths, facts, controversies, mysteries associated with these type of anesthesia, regional anesthesia in patient anticoagulants. And I think it's better to go for this class. It was required. So I welcome you all to this class, all the seniors and all the postgraduates. I think we should kickstart the proceedings from here. Dr. Anu, you can proceed with the rest of the class.
Yeah, thank you. I would like to introduce Dr. Manaswini, my co-screen coordinator, to introduce today's faculty. Welcome, Manaswini.
Thank you, Anusha. Good evening, everyone. I'm Dr. Manaswini, Assistant Professor of Kamineni Academy of Medical Sciences and Research Center, Hyderabad. I would like to introduce the faculty. I would like to introduce Dr. M. Viresham sir, Professor and HOD, Department of Anesthesia, Kamineni Academy of Medical Sciences and Research Center. Sir is a regular faculty in state, zonal, national conferences, and regular examiner and thesis evaluator for MD and DNBE examinations in the southern states. Areas of interest: regional anesthesia, difficulty in airway, former president of ISA Telangana. And sir received Proficiency Award for exemplary services in field of anesthesia in 2016 from ISA National. 26 years of teaching experience as a postgraduate teacher and presented papers in indexed national and international journals.
Thank you.
Welcome, sir.
Thank you very much.
I would like to introduce Dr. Vidita K, Professor in Department of Anesthesiology, Kamineni Academy of Medical Sciences, PG teaching experience of 9 years and 6 research papers in national and international journals. Achievements are as a faculty in NOICE 2023, NIMS Hyderabad, MPU member in the institute, certified in BLS and ACLS, BCBR 8Com, CISP 2, and ma'am is also a MD internal examiner. Welcome, ma'am.
Thank you, Dr. Manaswini.
I would like to introduce Dr. Lakshmi Priyanka, Professor of Department of Anesthesiology in Kamineni Academy of Medical Sciences, PG teaching experience of 8 years and specialty interest in ultrasound-guided regional anesthesia, neuroanesthesia, perioperative pain medicine. And ma'am has done 7 publications in indexed national and international papers. Achievements are Fellow of Daradia Pain Management and certified course in BLS, ACLS and BCBR. Welcome, Priyanka, ma'am.
Thank you, Dr. Manaswini.
I would like to introduce Dr. Suresh Kumar. He's Chief Cardiac Anesthesiologist in Kamineni Hospitals. Areas of interest, cardiac and thoracic anesthesia, anesthetic management of minimally invasive cardiac surgery, and management of one-lung ventilation. 5 publications in national and international index journals, successful conduct of anesthesia for heart transplantation in a polio patient, and conduct of anesthesia for more than 2,500 cardiac cases. Welcome, sir.
Thank you, Dr. Manaswini.
Now I introduce Dr. Anusha, Assistant Professor in Kamineni Academy of Medical Sciences, PG teaching experience of 2 years, specialty interest, ultrasound-guided regional anesthesia, and publication in indexed international paper and poster presentations in national and international conferences, certified course in BLS and BCBR. Welcome, Anusha.
Thank you, Dr. Manaswini.
And today's instructions for the session is I would request all the participants to mute the audio and off the video during the session. And queries should be shared or asked in the chat box. And all the queries will be answered at the end of the session. I kindly request Dr. Viresham sir to take over and moderate the session forward.
Thank you, Manaswini. Good evening, dear faculty and my students. First of all, I will thank you, the ISA National Governing Council and the faculty of PG online classes for giving me this opportunity to be associated with you of today. Especially Dr. Sukinder Singh Bajwa, Honorary Secretary of the ISA National, and Puddi Madam, Madhuri Puddi Madam is really behind this all these things. And both of them are doing this online PG classes for the benefit of the postgraduates and some of the practitioners also. So this is a very good online program for the faculty and students. And for this, I am very much thankful to the ISA Governing Council President, Dr. Divatia, Vice President Ganesh Prabhu, ISA National Coordinator of Academics, Dr. M.D. Dineshwar, and the President-elect is Bala Venkat. So I'm thankful to the Governing Council for giving this opportunity. Thank you. Let me know that today's topic is anticoagulants and regional anesthesia. As being a postgraduate from the first year onwards, we are very much exposed to the regional anesthesia. This is the day in and out, every day, every anesthesiologist we have. This regional anesthesia techniques every day we are following both in the OR. And some of the peripheral nerve blocks also we are doing sometimes in the pre-operative area also, PAC rooms also. So not in PAC rooms, in the pre-op area. So this is a very, very important topic. Because regional anesthesia, so many patients coming for the different problems. Why it is regional anesthesia is very much advantageous is, so this is central neurological blockade, it takes over general anesthesia. Because the preservation of the respiratory function is intact, and reduced risk of aspiration, hemodynamic stability is better, reduced use of anesthesia drugs, and there is quick recovery, less cost to the patient, and less risk of deep venous thrombosis also is one of the important terms. And this is very good provided if you take care for the high-risk patients who need below umbilical surgery, especially in orthopedics and obstetric patients. So, a reduced healthcare cost, everybody likes to have in small nursing homes to institute for regional anesthesia, that is important. So, in this context, I introduce my postgraduate, Dr. Shirisha Gundu, third-year junior resident, who is going to talk on case presentation with a cardiovascular patient. What are the precautions you should take in the PSC, and what drugs he is taking, and what to be counteracted with the drug. These are all things we will be sharing with the faculty and postgraduate students. I invite Dr. Sirisha to present the case. Dr. Sirisha, am I audible?
Yes, sir.
Dr. Sirisha.
Dr. Sid.
Yes. Yes. Thank you so much, sir.
Dr. Sirisha, please widen your slides.
Yes, ma'am. Yeah. Are my slides visible, ma'am?
Yes.
Yeah.
Sirisha, I would
so-
like to interfere once you are presenting in the slides also. Okay?
Yes, sir. Sure.
Okay.
Firstly, good evening, everyone. I would like to thank my HOD, Dr. Viresham sir, for giving me this opportunity to present on the ISA National PG platform. And also, I would like to thank my moderators, Dr. Priyanka and Dr. Vidita ma'am, and my screen coordinators, Dr. Anusha ma'am and Dr. Manaswini ma'am, and my senior, Dr. Nitish sir, and also our Honorable ISA Secretary, Dr. Sukhminder sir, and Dr. Madhuri ma'am for giving me this opportunity. So, firstly, I'm going to talk about a case. So, the case is about an 80-year-old male patient, Mr. Raju, who had a history of fall and acetabular fracture of left hip, and he was posted for left bipolar hemiarthroplasty. So, in the pre-anesthetic evaluation of our patient, patient has a history of dyspnea on exertion since 6 months, which was NYHA grade 3, which was insidious in onset and gradually progressed to the present condition. And patient also has a history of unstable angina in 2023. And Mr. Raju is a known case of type 2 diabetes since 15 years and is on tablet vildagliptin 50 mg twice daily and tablet metformin 500 mg twice daily. And he is also a known case of hypertension since 15 years on tablet ramipril 2.5 mg once daily. And he is a known case of coronary artery disease and has undergone PTCA in 2008 for LAD and PTCA to RCA in 2023. And he is on tablet ecosprin 75 mg once daily and tablet ticagrelor 90 mg 90 mg once daily since 1 year.
Dr. Shirisha,
Yes,
go
sir.
go to the back slide.
Sir.
So, can you define what is the New York Heart Association grade 3 for the benefit of the postgraduate?
Yes, sir. So, in the NYHA classification, usually in any patient who is having a dyspnea, we try to classify them according to the NYHA gradient, that is New York Heart Association, sir. So, in the class 1 NYHA grading, the patient will have no limitation of the physical activity. That is, ordinary physical activity does not cause any fatigue or exertion or palpitation to the patient. Whereas in class 2 dyspnea, there is a slight limitation of the physical activity, sir. Patient should be comfortable at rest, but any ordinary activity will result in fatigue. Whereas in the class 3 NYHA grade 3, there will be marked limitation of the physical activity. Patient will be comfortable and rest, and but more than ordinary activity. Like if he's able to climb 1 flight of stairs usually, and if he's trying to climb 2 flight of stairs, then the patient will have palpitation and dyspnea, sir. And in class 4, the patient is unable to carry out any physical activity. That is, the patient will have dyspnea at rest also. So if any physical activity is undertaken, like less than normal physical activity, like walking towards the bathroom also, the patient will have discomfort.
What are the parameters in the NYHA class dyspnea? What are the parameters?
In this, we will usually, the parameters considered as a physical activity of the patient, sir.
Then what is unstable angina?
Sir, unstable angina meaning the patient is not having any angina when he is in sitting position or when he is in rest. But when he is trying to perform any activity more than his ordinary daily activity, the patient is having a pain. And the pain is also not constant or consistent. It is not constant, but it is increasing with activity.
Unstable angina. Okay. Go ahead.
Okay. So in the previous history, patient had no previous history of surgeries. He consumed a mixed diet and had a normal bowel and bladder movements. Mr. Raju is an ex-smoker and he stopped smoking around 20 years ago. And, and he was an occasional alcoholic and he stopped drinking 10 years ago. And he has no history of allergies to any food or any medications. And the patient has no history of cerebrovascular accidents or recent upper respiratory tract infections, jaundice, epilepsy, or thyroid disease. In the general examination of the patient, so his height was around 163 centimeters, weight around 57 kgs, and he was of lean build. Patient was conscious, coherent, and oriented to time, place, and person. There was no signs of pallor, icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema. And the oral cavity examination of the patient has shown that he was edentulous, and his tongue was normal in size and texture. The cervical spine of the patient had normal flexion and extension, and he has no history of cervical neuralgia. And the lumbar spine has shown no signs of scoliosis or kyphosis. And the vitals at the time of examination were 130 by 80 millimeters of mercury blood pressure, pulse rate of 70 beats per minute, and saturations of 96% at room air. In the airway examination of the patient, the temporomandibular joint movement was normal. The thyromental distance was more than 6 centimeters, and his mouth opening was around 3 fingers, and his Mallampati grade was 2. In the systemic examination, cardiovascular system S1 and S2 was heard in all the areas. In the respiratory system, bilateral air entry was present, and there were no added sounds. And per abdomen, it was soft, non-tender, and there was no organomegaly. And in the CNS examination, there was no focal neurological deficit. And the ECG of the patient has shown T-wave inversions in V5 and V6 leads with no acute ST changes. And the 2D echo has shown a concentric LVH. And there was also a regional wall motion abnormality in the inferior and posterior wall. And grade 1 diastolic dysfunction. And there was a fair LV systolic function, mild tricuspid regurgitation, and no pulmonary artery hypertension. And his ejection fraction was around 54%. So in the general investigations, the chest X-ray had a cardiomegaly with an aortic knuckle calcification with normal lung fields. And laboratory investigations of the patient has shown a CBP with a HB of 12.7% and a total leukocyte count of 11,450 and platelet count of 2.4 lakhs. And in the RFT, the blood urea was around 17 and serum creat of 0.8. And serum electrolytes, sodium 135 milliequivalent per liter, potassium 4.3, and chloride 98. His TSH was 1.02, and in the random blood sugar was 175 milligram per deciliter, which was borderline. And the coagulation profile, the prothrombin time has shown to be 11.9 seconds. His INR was 0.9, with a APTT of 27.6 seconds. Now, the plan of anesthesia for this patient, we have formulated to be a combined spinal and epidural analgesia. Cardiology consultation was obtained and the patient was stratified as mild risk for non-cardiac surgery. And he was advised to stop tablet ticagrelor 5 days prior to surgery. And he was started on injection heparin 5000 international units subcutaneous BD for bridging, and it was stopped 6 hours prior to the surgery. And he was also advised to stop tablet ramipril 2.5 mg on day of surgery, and he was advised to take amlodipine 10 mg on the day of surgery. And he was also advised to stop oral hypoglycemic agents on the day of surgery and advised for NBM from 12 a.m. midnight. And PT, INR and APTT was checked again on the morning of surgery, which has revealed PT to be 12.3 seconds, INR 1.02 and APTT 39.8 seconds.
If this type of patient comes to you, what type of precautions you will take? In the morning, blood sugar, will you do it? Fasting blood sugar?
Yes,
you have
sir. We will.
stopped the overnight fasting.
Yes, sir. We
How to
will,
titrate?
after overnight fasting, since the patient is also a known case of diabetes, we will definitely ask for a fasting blood sugar and also serum electrolyte levels, sir. So we will make sure that his sugar levels are well within the normal range.
Okay.
And then, we have administered epidural anesthesia for the patient. So we try to do it in a single attempt under aseptic precautions with patient in sitting position under local anesthesia of 4 ml of 2% lignocaine in L1 and L2 space with an 18 gauge 2-Heuss needle. Lumbar puncture was done, and loss of resistance to air was obtained at 5 centimeter depth from the skin. An epidural catheter was placed and fixed at 9.5 centimeters, and confirmation was done with the fall in the column in epidural catheter. And
what is the importance of this pricks in this anticoagulated patient? Patient for regional anesthesia. What is the importance of pricks?
Sir, usually in the patients who are on anticoagulant and antiplatelets, the risk of bleeding is high. So when we are trying to minimize the number of attempts to administer epidural or spinal anesthesia, we are also minimizing the risk of patient having a spinal or epidural hematoma further. And also the risk of bleeding, we are trying to reduce as much as possible with the number of pricks we are trying to give, sir.
How many pricks we can allow with an experienced anesthesiologist? Not by seniority, it is by the regular practice. How many pricks will allow?
It is better to minimize the number of pricks to less than 3, sir.
Okay. Go ahead.
In the neuraxial blockade, we have administered spinal anesthesia at the level of L3, L4 with the patient in sitting position using a 25 gauge Quincke Babcock spinal needle, and after a backflow of clear CSF, 3.2 ml of 0.5% bupivacaine plus 0.2 ml of adjuvant, that is buprenorphine, was injected intrathecally, and we have attained a blockade of T6, sir.
Okay, this patient you have done, but
Yes,
after letting inside the theater, what monitors you are going to attach to the patient?
Okay.
You may be doing regularly, but you have to tell what monitors you are
Yes,
going
sir.
to. It is
So
in
before
the
the start
theater,
of
pre-op area, all those things you have to tell.
Yes, sir. So in the pre-op area itself, we have checked the blood pressure and saturation of the patient, sir, and that was well within the normal limits. And after the patient has been wheeled into the operation theater, then we have connected all the SA monitors that we have checked the baseline ECG before going for the procedure. Then we have checked the blood pressure, which was again around 130/80 pre-operatively also. And saturations were around 98% at room air inside the operation room, sir.
And what other precautions you will take? Is edentulous patient, if regional anesthesia are not going to get it, what precautions you are going to take? What things you will keep the ready
Yes, sir.
In the theater?
Yeah. Since the patient is of a geriatric age group, there definitely we had a plan B of giving a general anesthesia if our regional anesthesia is not going to happen as we planned. So since the patient is edentulous, we can be expecting a difficult bag mask ventilation, sir. So during that time, we have to keep all the, and also there can be a possibility of difficult airway occurring in this situation. So we have kept the difficult airway cart ready. And also during ventilating this patient, we made sure that there was a tight seal for the mask, so that there should be a tight seal for the mask. So luckily we did not encounter that situation, but in any edentulous patient, that is the precaution which we have to follow.
Go ahead.
The dosage and concentration of the epidural anesthesia was titrated according to the requirement and timing of the surgery, and patient was maintained with hemodynamically stable vitals throughout the surgery. And post-operative pain management was done with an infusion of 0.125% bupivacaine via the epidural catheter, and he was resumed onto heparin 5000 international units subcutaneous BD, and epidural catheter removal was done on post-operative day 2 after 6 hours of the last heparin dosage, and patient was resumed onto tablet ticagrelor 6 hours after removal of the catheter.
Something, are there any drugs which are going to interfere with the anticoagulants, whether they are going to increase this, whatever you have given in epidural and spinal anesthesia, the local anesthetic? Will
Yes,
they
sir.
interfere with the coagulation process, or are there any reports, or not there?
Sir, as far as my awareness goes, I haven't seen any reports of local anesthetics interfering with the anticoagulants or antiplatelets, sir.
Okay.
Okay, Dr. Sirisha,
Yes, ma'am.
as per your history, patient is a known case of CAD with unstable angina and
Yes.
with a past history of PTCA to LAD and RCA.
Yes, ma'am.
So, if the patient has to position himself for regional anesthesia, as you said, combined spinal epidural anesthesia, for him to give a suitable position, definitely you have to give some regional block
Yes.
to make him pain-free. So, what would you consider in this case?
So, ma'am, actually, we also had this plan of administering any regional block to ease the patient for positioning. But we,
It's not
in this
regional
case,
block.
we could have given a pericapsular end nerve group block, ma'am, the PENG block. So that would have made positioning easy for the patient, because usually in patients with a hip fractures, PENG block is ideal for reducing the pain for positioning. But in this patient, we have tried to put the position, and the patient had cooperated for the position. So we thought it was not necessary to administer a PENG block for this patient.
Okay. So, one more question.
Yes, ma'am.
So, see, epidural space is with venous plexuses, right? So
Yes,
that is
ma'am.
why when you prick it, you're more prone for getting epidural hematoma. So which
Yes.
part of epidural space has got more venous plexus?
Ma'am, the lumbar epidural space has.
No, I'm talking about the columns. See, usually the anterior and lateral part of the epidural spaces has got venous plexus. So if you go lateral part or you hit the anterior part of the columns, it'll have venous plexus. So there is a more common incidence of epidural hematomas if you go laterally or if you touch the anterior part of the epidural space. Just for the information. Okay.
Yes.
Next.
Dr. Sirisha?
Yes, ma'am.
Yeah, thank you for the presentation. Can you briefly enumerate the coagulation cascade for us?
Sure, ma'am. The coagulation cascade, it comprises of two major pathways, that is the intrinsic pathway and the extrinsic pathway. The intrinsic pathway is activated by the contact activation. So the activation of this pathway usually occurs because of the collagen molecules with a negative charge. The collagen activates the intrinsic pathway inside the blood. So whenever there is activation of the intrinsic pathway, there will be factor 12 activation followed by factor 11, factor 9 and factor 8, which will combine and finally activate the final common pathway, that is the factor 10A. So in the extrinsic pathway, there is the activation of the tissue factor first, and the tissue factor, this tissue factor is present outside the blood vessel. That is why this is called as the extrinsic pathway. So this tissue factor will again activate factor 7 to factor 7A, and this factor 7A in turn activates the final common pathway, again the factor 10. So from the final common pathway, the factor 10, there will be activation of factor 2, that is prothrombin to thrombin, and also there is activation of factor 5 to factor 5A. So this activated thrombin, that is factor 2A, moves to activate the fibrinogen to fibrin, and here there will be a fibrin stabilizing factor, that is the factor 13 coming into play, which will stabilize the fibrin clot that is formed, and it will form the final fibrin clot that is required for the coagulation. Now, in this pathway, we also have anticoagulants that is mediated by thrombin and the thrombomodulin complex. So, we have protein C and protein S, which are the natural anticoagulants that occur in the circulation. So, protein S is the cofactor for the protein C, and this activated protein C and also antithrombin 3. So, these two are the factors which are the common anticoagulants, antithrombin, which mainly inhibit the factor 10A, factor 2A, but antithrombin also inhibits the factor 8, factor 9, factor 11, and factor 12.
Okay, thank you. And any other model of this coagulation?
Yes, ma'am. In the recent times, we have come across another new model of the coagulation, that is the cell-based model of coagulation. So in this cell-based model of coagulation, basically it is the main thing that is postulated here is the endothelial cells. The damaged endothelial cells play a major part in the coagulation pathway, which we are usually ignoring in the normal coagulation cascade. So in the cell-based model, there are three phases. That is, the first one is the initiation phase, amplification phase, followed by the propagation phase. So in the initiation phase, we have the tissue factor bearing the fibroblasts. So the fibroblasts, which are usually present in the any injured part, so that has a tissue factor. Now this tissue factor, as we've seen in the intrinsic pathway, first it will go and stimulate the factor 7. Factor 7 is activated to factor 7A. So after this, this initiation it generates a small amount of factor 9, factor 10, and thrombin by tissue factor complex, tissue factor and factor 7 complex. Now this is called as the extrinsic kinase complex. Now after this, the amplification phase is followed. This amplification phase, it happens usually on the surface of the platelets. Activation of platelets, it also activates the glycoprotein 2B and glycoprotein 3A receptors, and this causes the release of von Willebrand factor from the endothelial cells, and it also causes the activation of factor 5 and factor 8, factor 11 on the platelet surface. After this activation, this amplification process occurs on the platelets, then it will move on to the propagation. That is some amount of the platelets that are participating in this activity, they will go on to release more and more of thrombin, and they will also signal more platelets to be recruited into this. So that includes the generation of factor 10A and the factor 10A, factor 9 and factor 8 complex. That is called as that is called as the intrinsic kinase complex. And intrinsic kinase complex and the extrinsic kinase complex finally form a prothrombinase complex here. If we can see, the factor 9A and factor 8A along with the phospholipids and the calcium, they form the intrinsic kinase complex. And the extrinsic kinase complex is formed by the tissue factor, factor 7A, phospholipids and the calcium, and these both activate the prothrombinase complex. Now this prothrombinase complex, it helps in conversion of prothrombin to the thrombin, and that finally converts the fibrinogen to fibrin. And this fibrin, again, due to the action of the fibrin stabilizing factor, it has a propensity to form a strong clot that is stabilized.
Okay.
Yes, ma'am.
Okay, Sirisha, now what does PT and INR measure? And what does APTT measure?
Okay. So, ma'am, when we are testing the prothrombin time of a patient, we are usually testing the extrinsic pathway as well as the final common pathway. So what we do in this prothrombin time is basically we add a tissue factor, that is a major stimulating factor for the extrinsic pathway, as we've seen in the coagulation cascade. So when we add a tissue factor to a sample of plasma and we measure the time it takes for the sample to clot. So this tissue factor activates the extrinsic pathway, which in turn activates the final common pathway. And the rate of extrinsic pathway is mainly influenced by the amount of factor 7 we have. And factor 7 usually has a short life, a short half life, and it depends, and it is also dependent on vitamin K. So the testing the prothrombin time is a way of looking at the function of vitamin K dependent enzymes, usually the factor 2, factor 7, and factor 10. But factor 9 is also vitamin K dependent, but it is not usually tested in the prothrombin time. And after measuring the PT, we usually get a ratio, the ratio of given PT to an average PT, which is called as the INR, that is the International Normalized Ratio. And INR is actually most sensitive to the clotting factor 7 and factor 10. So the INR value is prolonged when the factor 7 is usually reduced to approximately 55% of the usual baseline levels. So an INR of 1.5 is usually associated with a factor 7 activity of 40%. And an INR less than 1.5 should therefore be associated with normal coagulation. So now this is the reason we usually take 1.5 INR as the cutoff for all the neuraxial procedures. And then we also measure the activated partial thromboplastin time, that is the APTT. This is the test for the intrinsic pathway as well as the final common pathway. So now in this, what we are doing is we are adding some partial thromboplastin to the blood sample. So this thromboplastin is usually a surrogate for the tissue factor. So what we have done is in this is we have removed this tissue factor part from this thromboplastin, and hence it is called as a partial thromboplastin. So that partial thromboplastin is only the phospholipid part. So the phospholipid part is the main part that activates the intrinsic pathway. So when we are removing the tissue factor here, we are making sure that the extrinsic pathway is not coming into the in between the pathway we are testing here. So there is no extrinsic factor activation in this test. So in order to kick off the intrinsic pathway, some sort of negatively charged substance must be present. For example, in the living tissue, this is the collagen exposed by the cutting vessel. So in the laboratory setting, we usually, instead of collagen, we have kaolin or silica. So the phospholipid and the calcium are required for this. As we have seen, the phospholipid and calcium are required for the intrinsic T-nase complex and the prothrombinase complexes, and also for the final common pathway. So now this calcium also participates in this intrinsic pathway. So what happens is when this APTT is a key analysis in the setting of specific suspicion in the patients who are presenting with bleeding tendency or for monitoring hemophilia or unfractionated heparin. So, and this APTT is also useful for us in monitoring the argatroban treatment and also parenteral direct thrombin inhibitors, that is used in patients with thrombosis or heparin-induced thrombocytopenia. And APTT is also requested to detect the presence of autoantibodies associated with the risk of thrombosis, like lupus anticoagulants. So finally, if the APTT is prolonged, that means the intrinsic pathway has been impaired in any of the step. It could be within the coagulation factors or within the mechanism that is happening between the coagulation factors. So we are in this isolated prolonged APTT, it usually occurs in acquired hemophilia with autoantibodies and typically targeting the coagulation factors of factor 8 or factor 9. So in the latter condition, that is acquired hemophilia, it is usually rare and it is usually presents with a marked bleeding phenotype. But in a way of testing APTT, we are testing the authenticity of the intrinsic pathway. That is, we are trying to see if the coagulation factors are missing or if any of the steps of the pathway has been impaired.
As a general rule, Srisha,
Yes,
how much
sir.
percentage of the coagulant should be there to have a normal hemostasis? Minimum, at least.
Yes, sir. So for us, at least 40 to 50% of the coagulation factors should be intact for a normal coagulation to take place, sir.
No.
So
100%,
when the
90%, 100% is not necessary. Only
yes, sir.
this is very common in those patients where they are having liver disease and renal disease, either prolongation of the bleeding tendency or the coagulation of the risk impaired.
Yes, sir.
So minimum, if the patient is bleeding, means the clotting normal factors are deficient less than 30%.
Yes, sir.
Sirisha,
Yes, ma'am.
yeah, can you please classify the anticoagulant drugs?
Yes, ma'am. So, ma'am, the anticoagulants are broadly classified into parenteral and oral anticoagulants. In the parenteral and oral anticoagulants, again, we have indirect thrombin inhibitors and direct thrombin inhibitors. The indirect thrombin inhibitors are heparin, low molecular weight heparin, and fondaparinux, whereas the direct thrombin inhibitors are bivalirudin, argatroban, and lepirudin. Whereas in the oral anticoagulants, we have factor 10A inhibitors, that is rivaroxaban, apixaban, and edoxaban. And direct thrombin inhibitors are dabigatran, and vitamin K antagonists are warfarin.
Okay.
Okay, Sirisha, now can you briefly tell about warfarin and why does warfarin take several days for its onset of action and also offset of its action?
Yes, ma'am. So the main activity of the warfarin, it usually exerts its anticoagulant effect by interfering with the synthesis of vitamin K dependent factors, ma'am. That is usually the factors 2, 7, 9, and 10. And it also inhibits the anticoagulant proteins, protein C and protein S. So if we see here, it is warfarin is affecting both the anticoagulant factors and the procoagulant factors. So the onset of action of warfarin, it is usually typically within 24 to 72 hours. So a peak therapeutic effect is seen in 5 to 7 days after the initiation. So, however, we usually measure the patient's INR within 24 to 36 hours. During that time, the INR reading may not be reliable. So, what happens is the initial prolongation of the INR is the result of competing effects of the reduced factor 7 and protein C, and there will be washout of existing clotting factors that is happening. So now, because of this, INR is unpredictable during the initial stage of the treatment of warfarin. So that is, if we see the procoagulant and the anticoagulant coagulant factors, both of them are depleted because of the warfarin action. So because of that, we can't rely on the INR that we get in the initial stage of treatment. But after 72 hours, as this anticoagulant activity dominates the procoagulant activity, at that time the INR can be taken into consideration.
Okay. What is the difference between the low molecular weight heparin and fractionated heparin and heparin?
Yes, sir. So, in the unfractionated heparin and low molecular weight heparin, sir. Unfractionated heparin, the action is it activates the antithrombin 3, sir. Now, antithrombin 3, it forms a complex inhibiting the clotting factors 2A and the factors 10, sir. Inactivates the factors 2 and factor 10, sir. And it also inhibits the factors 9, factor 11, and factor 12. Whereas if we see the low molecular weight heparin, it it is a synthetic derivative of the it is enoxaparin and fondaparinux. Fondaparinux is the example, that is a synthetic derivative of low molecular weight heparin. This also activates antithrombin 3, and it also forms a complex that inhibits a clotting factor only 10. So if we see here in the low molecular weight heparin, that inactivates only the factor 10, whereas unfractionated heparin has several other factors on which it acts. And unfractionated heparin, usually it is administered intravenously, and low molecular weight heparin is usually given subcutaneously. And unfractionated heparin, the duration of action is only usually it is around only 1 hour. The half life is around 1.5 to 2 hours. And the low molecular weight, if low molecular weight heparin, if we see, it has a longer half life of around 3 to 6 hours. And for fondaparinux, which is a synthetic anticoagulant, the half life is around 17 to 21 hours. And the side effects of unfractionated heparin are, we can see bleeding, osteoporosis, and mainly thrombocytopenia, that is heparin-induced thrombocytopenia, and also hyperkalemia. Whereas in low molecular weight heparin, the bleeding, osteoporosis, and thrombocytopenia is also there, but it is to a very lesser extent, not as much as we seen in unfractionated heparin. And unfractionated heparin is rapidly reversed by protamine sulfate. And it is usual in situations where we need a rapid reversal of heparin. Whereas in the low molecular weight heparin, it is not rapidly reversible. It is only partially reversible by protamine sulfate. And in renal failure, unfractionated heparin is preferred over low molecular weight heparin. Low molecular weight heparin, it is used with caution. So it should be usually avoided if the GFR is less than 30 due to increased risk of bleeding again. And when we are giving unfractionated heparin to the patient, the patient should be usually under therapeutic monitoring, and because it carries high risk compared to low molecular weight heparin. And the risk of, as I said, the risk of heparin-induced thrombosis is also high with unfractionated heparin. And with low molecular weight heparin, there is a low risk of heparin-induced thrombosis. And with drugs like fondaparinux, there is no risk of heparin-induced thrombosis, sir. Thrombocytopenia.
Okay. I think we will.
Sirisha,
Yes, ma'am.
can you briefly talk about direct acting oral anticoagulants and how are they better when compared to warfarin?
Yes, ma'am. The direct acting, the novel oral anticoagulants, usually these are indicated in prevention of stroke and systemic embolism in adults with non-valvular atrial fibrillation. That is, patients who have one or more risk factors, such as patients who have had a prior episode of stroke or transient ischemic attack and age more than 75 years, and patients with hypertension, diabetes, or symptomatic heart failure. So the advantage with novel oral anticoagulant agents is, unlike warfarin, they have a predictable therapeutic response. So we've seen with warfarin, the INR is not really predictable within the first 24 to 72 hours. So that problem we will not encounter with these novel oral anticoagulant agents. And also the onset of action is rapid with these. And there are few drug interactions, and there is no requirement for regular coagulation monitoring in the patients whom we are administering novel oral anticoagulant agents. So the most commonly used are the first one is dabigatran. Dabigatran is it is a direct thrombin inhibitor, and in this the most important point which we should remember about dabigatran, that is it is the renal excretion is 80%, that is 80% of dabigatran is excreted via renal pathway. So while we are administering dabigatran to a patient who is having a chronic renal failure or any acute renal conditions, we should be very careful about the dosage. And the other drugs are rivaroxaban, apixaban, and endoxaban, which are direct factor 10 inhibitors. In this, the rivaroxaban is mainly and most commonly used. That is, in this rivaroxaban, the renal excretion is usually around 35%. And in the apixaban, apixaban and endoxaban, these are also used to prevent venous thromboembolism.
Okay. So in while using direct acting oral anticoagulants, sometimes bridging therapy is also not required in compared
Yes.
to warfarin.
Yes.
And okay. So now can you classify antiplatelets based on their mechanism of action?
Yes, ma'am. Now, the antiplatelet drugs, depending on their mechanism of action, the first group of drugs is the drugs acting on the adenosine diphosphate, that is the ADP antagonists, which are ticlopidine, clopidogrel, and prasugrel. And we have COX inhibitors, which are the first group of antiplatelet drugs, which is aspirin. Then we have phosphodiesterase inhibitors, that is dipyridamole. And we have glycoprotein 2B and glycoprotein 3A inhibitors, which are tirofiban, eptifibatide, and abisiximab. And depending on the site of action, if we see here, the aspirin, which is a non-steroidal anti-inflammatory drug, it mainly acts on the cyclooxygenase 1 pathway, and it will inhibit the synthesis of thromboxane A2. And this thromboxane A2 is it actually induces the platelet aggregation, and it is a potent vasoconstrictor, and it induces the vascular smooth muscle contraction and vascular smooth muscle proliferation. So it is a pro-atherogenic factor, and when we are giving aspirin to the patient, we are blocking this thromboxane A2. And the phosphodiesterase inhibitors are cilostazol and dipyridamole here, and the drugs that act on the P2Y12 inhibitors, that is clopidogrel and prasugrel, and which is a reversible ADP inhibitor, that is the ticagrelor we have, and and the direct thrombin inhibitors are voraxaparvam.
Okay. Apart from ticagrelor, what is the other one which is short acting, which belongs to the same group, reversible ADP receptor antagonist?
Prasugrel, ma'am.
Hungry.
No.
Hungry.
Cangrelor.
Cangrelor.
Cangrelor is an IV antiplatelet agent, ma'am. Yes.
Cangrelor is not IV.
Yes.
It is a reversible agent. It is a
IV.
reversible P2Y12 antagonist, just like ticagrelor, but it is short acting.
Okay.
IV agent. Right. Okay. Can we go to next speaker now? Be on the screen and be available, Sirisha.
Yes, sir.
Now I introduce next presenter, Dr. Nitish Chandra. He is the senior resident. He is working with our faculty in Combination Institute of Medical Science and Research Center. And now I asked him to come to the review room, and then you present your on especially guidelines to be considered for regional anesthesia and peripheral narrow blocks for chronic pain management. What are the guidelines available? And kindly enumerate those things to the audience and faculty. Dr. Nitish.
Oh, yes, sir. I'm available. Thank you, sir. Thank you. Myself, I am Dr. Nitish Chandra, Senior Resident, Department of Anesthesiology, Combination Academy of Medical Sciences and Research Center.
Your slides are not shared.
1 second, sir. I'll share.
Dr. Sirisha, kindly stop sharing.
And stop sharing.
Sirisha, are you here?
No, please.
Sir, are my slides visible, sir?
Yeah, yes,
Yes,
Nitish,
yes.
carry on.
Yeah. So firstly, I want to thank my HOD, Dr. Veeresham sir, for giving me this opportunity. And I want to extend my thanks to my professors, Dr. Vidita ma'am and Dr. Lakshmi Riyaka ma'am. They have been guiding me and mentoring me since my first year of post-graduation. And I continue my thanks to Dr. Suresh sir, the cardiac anesthetist. And I want to thank my seniors, the screen coordinators, Dr. Manaswini ma'am and Dr. Anusha ma'am. And I also continue my thanks to Dr. Sukhminder Bajwa sir. He has been continuously supporting me and encouraging me. And this is the third opportunity which he has given me. And thank you, Sirisha. That was a very good class, an excellent class. You have covered almost all the domains and made my job very easy. So yeah, now I'll start my class on ASTRA guidelines and implications. I know it's a bit boring class, but I'll try to make a bit more interesting. Yeah. So what is ASTRA? ASTRA is American Society of Regional Anesthesia and Pain Medicine. And why these guidelines are important? These guidelines give us some therapeutic how to go with respect to the anticoagulation agents and antithrombotic and thrombolytic agents, especially in the patients who are taking regional anesthesia. And what are its aims? Prior in the first consensus, their primary focus was completely upon the neuraxial bleeding. But as the additions keep on revising, they have even included the prevention of perioperative venous thromboembolism, and they even included the pain procedures and regional blocks as well. Now, yeah. So the first two consensus of the ASTRA guidelines, that is the first two meetings which happened in 1998 and 2003, their primary focus was upon the neuraxial blocks and the anticoagulation in the surgical patients. In the year 2010, that is a third edition, which they have updated the prior guidelines. And here the major change they included is Prior, the parturients were, since the pregnancy is a hypercoagulable state, the parturients were given a bit of thromboprophylactic agents. But here they clearly told that the parturients can be managed similar to the non-pregnant patients. And this they have done in association with a National Partnership for the Maternal Society and Society for Obstetric Anesthesia and Perinatology. Now, the guidelines which we are discussing, the present guidelines, that is a fourth edition, and that is in the 2018. They have even included the placement and removal of spinal or epidural catheters. Yeah. So now, on what basis these drugs are stopped or restarted before the for any neuraxial procedures? Here they basically included the time in half-lives. That is the time interval between the therapeutic anticoagulation and the subsequent neuraxial blockade should be the 5 half-lives, and is usually dependent on renal function. And if the patient is having any additional comorbidities and the renal function is not abnormal, the half-life, the duration that we have to wait should be longer enough. And the time interval between the prophylactic anticoagulation and the subsequent neuraxial blockade should be 2 half-lives. Why? This based on the studies, they told that if you wait for these amount of half-lives, the resolution of anticoagulant effect will be by 97%. Yeah. Now, Rosencher et al. Has done a work, and they told that for a platelet blood to become stable, it will take around 8 hours. So based on that finding, they told the subsequent dosing of any antithrombotic agent should be 8 hours minus the time it takes for the peak anticoagulant effect to occur. Just take an example. That means what he wanted to say is the efficacy of the thrombolytic therapy following an embolic clot will decrease after 6 to 8 hours, because what I told is for 8 hours the platelet plug becomes stable. So at that time the thrombolytic therapy effect decreases. So based on this, you have to understand that, example, take a low molecular weight heparin. The peak effect for the low molecular weight heparin to occur is 4 hours. So 8 hours minus 4 hours will be 4 hours. So you have to wait for 4 hours. And usually these recommendations are all made with a time interval, because every individual has to have a different pharmacological activity and there will be variation in it. Yeah. Now, these are strength and grades of recommendations that the ASRA usually gives. But remember, just remember as grade 1 and grade 2, because most of your guidelines are for grade 1 and grade 2. Grade 3 is not present in any of our guidelines. Grade 1 is a general agreement in the efficacy. Grade 2 is a conflicting evidence or opinion on the usefulness. So most of your guidelines are grade 1 and grade 2. Grade 1 is usually they recommend. That means we can follow it usually. And grade 2 is just they suggest. That means we have to decide based upon your clinical judgment whether we can go ahead or not. Yeah. Now, what are the current recommendations for the prevention and treatment of venous thromboembolism? I think most of the times, almost all the hospitalized patients have at least one risk factor, and 40 to 50% have 3 or more risk factors. Am I audible?
Yeah, go ahead.
Yes. So based upon the risks of the thromboembolism and bleeding, it's always the balance between the thromboembolism and bleeding. Based upon the balance, always take a call. So whether you'll go for a mechanical means or a medications or a combination of both. So the mechanical means, usually you get a compression stockings or you get an intermittent compression devices. Yeah. Next, what are the risk factors? You need not remember the entire list, but most of the times you have to know at least the risk factor that makes the patient immobile is always high risk. And you can remember something like an increasing age, pregnancy, obesity. These are small things you have to remember, but at least most of the times any surgery, trauma for the lower extremity, and any things that is called immobile for the patient. The patient is not able to move. Yeah. Now this is one risk category classification. Based on this, we can categorize the patient into low risk, moderate risk, and high risk for the venous thromboembolism. So you have certain risk factors which can contribute to 1 point, and you have certain risk factors which contribute to 2 points, and certain risk factors which are contributing to 3 points. Yeah, and certain risk factors which are contributing to 5 points. So you can, based on that, you can decide where the patient exactly categorizes into a low risk, which has a total score of 0 to 4, and moderate, which has a score of 5 to 8, and high risk category, which has a score of more than or equal to 9. So for women, you have an extra things like a pregnancy, recurrent or spontaneous abortion, oral contraceptives or hormone replacement therapy, because they are also an increased risk factors for venous thromboembolism. Yeah. It's okay. So this is again a small chart which in a very simpler format to explain you. So there are three categories: low risk, moderate risk, and high risk. So whenever it is low risk, usually you don't require any thromboprophylaxis. Early mobilization will be enough, or early mobilization or ambulation will be enough. Usually most of the minor surgeries patients and come under the low risk category. The moderate risk category, any small surgeries like open gynecological surgery and general open urological surgeries, they all come under moderate. They mostly require mechanical means like intermittent pneumatic compression, and sometimes they even require a pharmacological means like a low dose unfractionated heparin, which is 5,000 units. And sometimes they even require a low molecular weight heparin, that is a prophylactic dose. You require around 40 units subcutaneously, OD. And high risk, the patients who are undergoing any THR, TKR, major trauma, spinal cord injury, major surgery in patients who already had risk of previous VTE, they all come under high risk category. And there you require a therapeutic dose of the low molecular weight heparin, which will be around 60 units subcutaneous. And you require sometimes the higher drugs like warfarin and fondaparinux. Yeah. And now there are certain guidelines, that is anti-thrombotic prevention and prevention of thrombosis guidelines, 9th edition. Earlier guidelines, the 8th edition, usually include only 3 drugs, that is low molecular weight heparin, fondaparinux, and vitamin K agonists. This 9th edition have included the additional drugs, which include your dabigatran, rivaroxaban, apixaban, and low dose unfractionated heparin and aspirin. Usually this 89 guidelines have less aggressive approach, and they have a more options for thrombotic prophylaxis depend upon your clinical judgment. And always remember, as I always say, the selection of anti-thrombotic agents should always be balanced between the risk of bleeding and risk of thromboembolism. Yeah. This is again one more the small table where for any patient who is of very low risk, you don't require any prophylaxis. And for low risk, before that, you have to always see the patient whether he's having a high risk of bleeding or not. So most of the times, if he has a high risk of bleeding, irrespective of the risk of venous thromboembolism, you should only give mechanical prophylaxis, preferably with intermittent pneumatic compression. The pharmacological prophylaxis will be added until the bleeding risk diminishes. Till that, you don't add any pharmacological prophylaxis if you feel the risk of bleeding is very high. Yeah. Now, if the risk of bleeding is not high, then definitely you can add a pharmacological means, but usually you require it in moderate to high risk. You don't require in low risk usually. And the two, what I told, you require a low dose unfractionated heparin and a low molecular weight heparin usually. And for high risk surgeries, you will require therapeutic doses. And even you might require a post-discharge medications also you might require. Yeah. Now, how you will manage a perioperative management of patients on warfarin, pre-op and post-op. Pre-op, usually you have to discontinue the warfarin at least 5 days before the elective surgery. Since it's an elective surgery, you will have time. So assess the INR 1 to 2 days prior to the surgery. If it is more than 1.5, consider 1 to 2 mg of oral vitamin K. But ideally, if it's an emergency surgery, then you have to go for a IV vitamin K, not oral vitamin K. And IV vitamin K, 10 mg slowly can be given. And if you want an immediate reversal, the best thing you can give is prothrombin complex concentrates. And that too depends on the dose. If the INR is 2 to 4, you'll require around 25 international units per kg. If it is more than or equal to 4 to 6 INR, the prothrombin complex concentrate dose is 35 international unit per kg IV. If it is more than 6, the prothrombin complex concentrates dose is 50 international unit per kg. And the fresh frozen plasma, the dose is 10 to 20 ml per kg. Now, in the pre-op only, if the patient is at high risk of thromboembolism, he'll require a bridging therapy. If it is a low risk of thromboembolism, he don't require any bridging therapy. Yeah, the bridging therapy, usually you consider a therapeutic subcutaneous low molecular weight heparin, because since it is a high risk, you have to go for therapeutic. And you will require a IV unfractionated heparin, not low dose. It is an IV unfractionated heparin, not subcutaneous. And the last dose of the low molecular heparin, what you give is usually the daily dose. What you give, the half of the dose can be given 1 day prior. And post-op, again, you have to classify into low risk of thromboembolism and high risk of thromboembolism. If you feel the patient is on low risk of thromboembolism, resume the warfarin on the post-operative day itself. And if the high risk of thromboembolism, again, you have to see whether it's a minor surgical procedure or a major surgical procedure. If it's a minor surgical procedure, definitely the risk of bleeding is less, so you can resume the therapeutic low molecular weight heparin 24 hours post-operatively. If it's a major surgical procedure, definitely the risk of bleeding will be high, so you have to resume your therapeutic low molecular weight heparin 48 to 72 hours. And as I always say, assess the bleeding risk, and whenever the consider resumption of any of your low molecular weight heparin or unfractionated heparin. So it's always between the balance between the bleeding and thromboembolism. Now, the perioperative management of antithrombotic and antiplatelet therapy. The most of the antithrombotic guidelines will be given by American College of Chest Physicians, and you have to remember that usually most of your bare metallic stent or drug-eluting stent patients require an antiplatelet therapy. Usually they require a dual antiplatelet therapy, which includes a combination of aspirin and clopidogrel for a varying duration. And simple, what are I already told, it's the same. The perioperative management involves the balancing the risk of surgical bleeding and thromboembolism. If it's a high risk, you need a bridging therapy. If it's a low risk, you don't require any bridging therapy. Yeah.
Whether combination of antiplatelets and antithrombolytics is dangerous or single drug is better?
Usually it is dangerous, sir. It's better we go for a single agent. We should not go as a combination.
More risky for renal?
Yes, sir, more risky. In case of stents, we can go for a dual antiplatelet because they're going for a dual antiplatelet only. And it depends actually on the clot, sir, the mechanism of clot. In the artery, usually the clot is primarily formed by platelet. Therefore, in case of any of your CVA and MIs, we usually go for antiplatelet agents. Whereas in case of a venous clot is primarily formed by coagulation factors. Therefore, in case of a DVT and all, we usually go for anticoagulants, sir. So this is a mechanism we usually apply there. Yeah. Yes, sir. Can I go ahead, sir?
Go ahead.
Yes, thank you, sir. Yeah, now the perioperative management of the patients on antiplatelet therapy, it is just a summary of the thing. So usually when the patients are on coronary stents, if it's an elective surgery, for bare metallic stents, you have to wait for 6 weeks. And for drug-eluting stents, you have to wait for 6 months. The drugs have to be discontinued. For bare metallic stents, you have less time, and for drug-eluting stents, you have more time because the drug-eluting stents have certain agents that are anti-proliferative and they can give more time for you. And if the surgery cannot be postponed, you have to continue throughout the perioperative period. Yeah. And again, you have to classify the patients at high risk of cardiac events and low risk of cardiac events. Because of high risk of cardiac events, exclusive of coronary stents, continue the aspirin throughout the perioperative period, discontinue the clopidogrel or prasugrel 5 days prior to the surgery, and resume thienopyridine 24 hours post-operatively. Thienopyridines are nothing but clopidogrels or prasugrels. And the patients at low risk of cardiac events, you have to discontinue the dual antiplatelet therapy. It will increase, 7 to 10 days. Earlier it was 5 days. And since there is a low risk, you can wait for 7 days as well. And resume antiplatelet therapy 24 hours post-operatively. Yeah. Now, about spinal hematoma. What is spinal hematoma? It is nothing but a symptomatic bleeding within the neuraxial axis or a spinal axis. It's a very, very rare complication, but once it occurs, it is very catastrophic. Based upon the extensive literature so far available, the incidence is very less. It is 1 in 1,50,000 in case of an epidural and 1 in 2,20,000 in case of a spinal anesthetics. Of course, all these literature are completely patients even included who are not receiving any thromboprophylaxis. So the patients who are having a normal coagulation status are also included in this literature. And always remember, the hemorrhage into the spinal canal most commonly occurs into the epidural space because you have a prominent epidural venous plexus available there. Yeah. Now, there's a review of literature where you have a 61 cases of a spinal hematoma that is associated with epidural or spinal anesthesia. And 60% of the cases, all these cases have occurred in the last decade. So I want to use the quote used by Dr. Bajwa, sir. He told nowadays 1 in 5 people are using on anticoagulants and antiplatelets. So that's why if you see the 60% of the cases have occurred in the last decade. So it has been increasing in the last 1 decade. Now, the same review where you see the 61 cases of spinal hematoma, 60% of the cases in that, if you see, the 25 received IV subcutaneous or low molecular weight heparin or unfractionated heparin, 5 are undergoing any vascular surgery, received the heparin, 12 have an evidence of coagulopathy, 15 there is a difficulty in the catheter placement, and 15 have a bloody catheter placement. Yeah. And now in these 61 cases, 87% either have a clotting abnormality or a difficulty in needle placement was present. And in the 61, 32 who have a catheter in situ have developed a spinal hematoma immediately after the removal of epidural catheter. So by this line, I want to clearly emphasize that before removal of catheter also, you have to be very, very careful. Yeah. And 15% have immediately developed after the removal of epidural catheter. Next. And how does these patients present? Most of the times, these patients present with a progression of the sensory or motor block. Very, very less group of patients have a bowel or bladder dysfunction. And most of the patients don't have any severe radicular back pain. And remember, only 38% or to 40% of the patients have a partial or good neurological recovery. And remember, this spinal cord ischemia can be reversed if a laminectomy has been done 8 hours of the onset of neurological dysfunction. So you just have a time of less than 8 hours. As I already told, the platelet plug to get stabilized, it will take around 8 hours. So you can apply the same concept here. Yeah. And
okay, how do you diagnose this complication? Because it has to be taken within 8 hours, the treatment to prevent the other neurological complications.
Sir, most of the time, sir, the diagnosis we have to see based upon the sensory or motor block, how the progression is present. If there is a progressive sensory or motor block is seen, then you have to decide, sir. Usually we think the weakness is something that is there. Usually that is not because of the spinal hematoma, sir. So usually to identify and diagnose to this, if we feel the patient is having a risk of developing a spinal hematoma, what the consensus guidelines tell is, we have to use, in case of an epidural catheter, you use always a low concentration of local anesthetic drugs that will not cause any motor or sensory blockade, that will have only analgesic effect, because it is easy for us to diagnose the spinal hematoma in case it occurs. That is what the consensus guidelines tell us. Because in case of a spinal hematoma, most of the times they present as a progression of sensory or motor block.
So if you get suspicion that there is a motor weakness, paralysis, then you will subject the patient for investigation, like MRI or so. Then you will come to know this is the problem, epidural hematoma is there. That's why then we will consult the subject is for consultant, orthopedic, for removal of that. Okay. Right. Go ahead.
So what is the time during which surgical intervention is required? Like
I didn't get you. Come on.
See, as soon as you detect the neurological complications, what is the duration you go for surgical intervention? Within how many hours?
Within 8 hours, ma'am. Within 8 hours.
Within 8 hours.
Ideally, I would say go as early as possible.
As early as possible, but don't postpone it.
Yes, ma'am. Because yes, ma'am, according to what you told is correct. Even the consensus guidelines say that most of the times the spinal hematomas cause these paraplegias because of the delay in the diagnosis and a delay in the intervention. If the intervention and diagnosis are done on time, most of the times, as these say, 38% have recovered. And once these condition occurs, usually 90% of the patients have developed a permanent deficit. So we have to be very, very cautious in diagnosing and doing any intervention. And especially the patients who are on vascular surgery and who's on IV heparin, we have to be much more careful, because more than half of the patients who have got this are on that. I mean, there is the 61 patients or whatever we got that literature. In that, more than half have received the IV heparin. Next, can I go ahead, sir?
Yeah. How do you manage this anesthetic management of patients receiving
thrombolytic therapy, sir? Yeah. So what the ASRA and ASRA guidelines consensus say that if the patient is on a thrombolytic, usually it's better you avoid any neuraxial procedure and avoid any catheter. But in case if it's done, in case you have done a neuraxial procedure, post neuraxial procedure, at least you have to wait for 10 days. That is what this consensus guideline says, and it says avoid the epidural catheter.
Okay.
Yes, sir. And in case, as I told, sir, in case if we have done a neuroaxial procedure, then the neurological monitoring has to be done, and it has to be done every second hourly. The neurological monitoring has to be done every second hourly, and it doesn't advise any epidural catheters. Usually say avoid. There's no definitive recommendations regarding that, sir.
I think while you are pricking the spine, back of the spine, you may have some bleeding, and you will know the patient may have this problem that premonitory signs you may get it. The patient is on anticoagulant.
Yes. Then we have to do the neurological monitoring, sir. Every second
Yes.
hourly monitor, because the early on right time, if we diagnose, we can definitely prevent the complications, and then we can intervene as well. Because sometimes MRIs can't pick early, so neurological monitoring is something we have to do. That is very important. That will give us some clue regarding is there any spinal hematoma or not. Yeah. So these are certain ASRA guidelines. I'll just display these, and usually you have 4 side headings before a neuraxial procedure and after a neuraxial procedure, when you have to start, and before the catheter removal, when you have to stop, for how much duration you have to stop, and after the catheter removal, after how much duration you can restart. So just an example, after heparinization, how much time you will wait for a neuraxial procedure, and after procedure, how much time you will wait for reheparinization. Similarly, before the catheter removal, how much time you will stop, and after catheter removal, how much time you will wait for reheparinization. So it's very simple. You can just follow like this. And yeah.
Individual drugs, it has been displayed. Okay.
Yes, sir. Yes. So these are certain.
Go through it, sir.
You can go through this. Here I want to add one thing. So just remember, in any factor 10A inhibitors, it's better you avoid the catheter. Better avoid. Certain guidelines say after medication, I mean, you can for 6 hours and like that, but it's better you avoid. So rather than creating any complications, better you avoid. Yeah, even for direct thrombin inhibitors, it's better avoid the catheters. And in case you have a catheter, avoid these drugs. I mean, you don't have an option. You have to go for an epidural. Avoid the drugs. Aspirin, as usual, there is no restriction for aspirin. For clopidogrel, you have to wait for 5 to 7 days. And for all the durations, you can follow this. And one thing I want to add for dabigatran usually depends upon the renal function. So if your renal function is normal, you have to wait for a certain amount of hours. And if your renal function is less, again, it will increase. So dabigatran always depends upon the renal function, because it's usually excreted via the kidney. So that is something you have to remember. And if you have any alternate, it's better go for an alternate drug if you have a renal impairment in case of a dabigatran. These are all the fibrinolytics. And if you want to give any neuraxial procedure, you have to wait for 10 days for any fibrinolytics. Yeah, these are glycoprotein 2B3A drugs. And here also you have to avoid catheters. You have to avoid catheters. And once the catheter is removed, you have to wait for 4 weeks for these drugs. This is something you have to remember. Yeah. Now I want to give the summary. So how you go, basically you have to have a checklist. So how you prepare a checklist? Basically, you have to have a history of all the signs suggestive of bleeding disorder, and check if a patient is having any unusual bleeding like epistaxis, menorrhagia, any family history, if the patient is on antiplatelet, antithrombotic, thrombolytic, and sometimes the patient might be on other drugs like SNRIs, SSRIs, and herbal therapies. They also have an influence in the coagulation. Based upon all the history, you will require to order any coagulation tests, and sometimes you have to identify. Now, aspirin, usually you will have two kinds of prophylaxis, primary and secondary. When you don't feel the patient might get any problem in the future, so you'll get a primary prophylaxis. Prior any disease, you'll give it. Secondary, after once the disease comes, you'll give it. So primary and secondary prophylaxis. And based upon the anatomical location, you have to decide intracanal or extracanal spinal procedures, cervicothoracic or lumbosacral. As my professor, Dr. Priyanka ma'am, has already addressed, at what area you'll get more risk of bleeding because of the lumbar venous plexuses. And you have to again check the certain radiographic images where you can identify if there is any spinal stenosis, any difficulty in spinal anatomy. And yeah, sometimes you have to even have a good pharmacological knowledge like drug elimination, and you can use the guidelines. However, the guidelines, I tell you, the most important, you have to have a clinical judgment along with the guidelines. Don't blindly follow the guidelines. Yeah, take home points. Just don't blindly fix for the neuraxial techniques. You have many alternate, since the invent of ultrasound, you can go for a regional blocks, you can go for a safe blocks, and you can even use IV medications if you feel the risk of bleeding might be more, or risk of hematoma might be more. And yeah, thank you.
Thank you, Dr. Nitish. And now,
one second, sir. These are my references, and I would highly recommend the first reference, that is this article by everyone. This gives a very great and detailed insight about this topic. And this Asra Pain Medicine Cogs, I never use that app. If you want, you can try. But the first, I highly recommend the first article to be read by everyone. And I thank everyone for listening patiently to me. Thank you. Thank you so much.
thank you, Suresh. Now we'll go for another faculty member who is going to present what the cardiac disease, cardiothoracic blocks. So he will highlight some of the things as per his the journals and all those things. Now I invite Dr. Suresh, Chief Consultant Cardiothoracic Anesthesiologist from Kamini Academy of Medical Science and Research Center. Now over to Dr. Suresh Esampalli.
Good evening, sir. Thanks for the introduction. First of all, I want to convey my thanks to my HOD, Dr. Veeresham sir, and my colleagues, Dr. Vidita and Dr. Lakshmi Priyanka, and my juniors, Dr. Sirisha, Dr. Nidish, Manaswini, and Anusha. And last but not least, Dr. Sukhvinder Bajwa sir, for giving me this opportunity to throw some light regarding cardiac blocks on patients with anticoagulants who come for surgery regularly with us. Now I'm going to share my slides. Is it visible, sir?
Yeah.
Yeah, today my topic is anticoagulants and regional blocks in cardiac surgery. What to do? So here I'm going to quote one journal which was published in Journal of Cardiothoracic and Vascular Anesthesia in February 2022. It's an original article. The topic is safety of ultrasound guided serratus anterior plane block and erector spinae facial plane blocks. It is a retrospective analysis in patients undergoing cardiac surgery while receiving anticoagulant and antiplatelet drugs. So it is basically a retrospective observational study which was conducted in Italy in University of Turin. The duration during between March 28, 2019 and October 19, 2020. In this, 70 patients were enrolled who underwent mitral valve surgery via right mini thoracotomy. Out of these, 35 patients were treated with continuous erectospinal block and 35 with continuous serratus anterior plane block. The primary objective here is to evaluate the number of blocks performed or catheters removed while coagulation was abnormal, or antithrombotic and anticoagulant therapies were in progress. So here comes the measurements and main results. 11 patients, which accounts for 15.7%, who received facial plane block with INR of more than 1.4, and 4 patients, which accounts for 5.71%, with a platelet count of less than 80,000, and 1 patient received electrospinal block during dual antiplatelet therapy. In 16 patients, which accounts for 22.9%, the catheter was removed with an INR more than 1.4, and in patients which accounts for 7.1% with a platelet count of 80,000, less than 80,000, and in 53 patients, which accounts for 75.71%, despite low molecular weight heparin at therapeutic dose. The median antagonist dose of vitamin K at the time of catheter removal was 2.5 mg is administered in both the groups. So they find no major adverse effects directly attributable to the blocks were observed. So the conclusion of the study is that the authors did not find any problems related to the use of continuous electrospinal block or a serratus anterior plane block, although they were performed in the presence of anticoagulation and in the context with a high-risk bleeding, such as cardiac surgery. Then next journal is, it is published in the ASRA Pain Medicine. It is a newsletter in 2018. The topic is, despite growing evidence for the efficacy of neurological analgesia, many anesthesiologists remain hesitant to use these approaches based on some unique considerations in the cardiac surgery populations. Here are some of the recent meta-analysis of neuraxial analgesia in cardiac surgery. One is Bignami et al., which was conducted in 2010, which includes 2,366 patients, which includes 33 patients. He has taken thoracic epidural anesthesia, which was supplemented with the general anesthesia versus general anesthesia alone for the cardiac surgical procedures. And they found that they have decreased incidence of acute renal failure and decreased mechanical ventilation and decreased composite mortality MI. And there is no effect of mortality and no change in the MI. And Sversovic et al. In 2011 conducted 20, it is a Cochrane review which has studied 28 studies, which includes 2,731 patients. Same thoracic epidural anesthesia is administered in supplementation with the GA when compared with the GA alone. So it has found that there is decreased incidence of supraventricular tachycardia and decreased respiratory complications, thereby decreasing the hospital ICU stay. Here also there is no increase, there is no change in incidence of mortality, MI and stroke. And Zhang et al. Conducted in 2015, which included 25 studies with the patients of 3,062 patients. Same thoracic epidural anesthesia is combined with general when compared with the GA alone. Here also they have found the decreased incidence of supraventricular tachycardia and decreased respiratory complications, decreased the intubation time and reduced ICU time. So this study also didn't show any effect on the mortality, MI and stroke. Neuraxial analgesia is administered in cardiac patients mainly for pain relief, but although it has some other advantage like sympatholysis of T1 to T4, thereby it provides the coronary vasodilation to the heart, which decreases the stress response of the heart and decreases the oxygen demand of the heart. Thereby, it increases the decreased incidence of supraventricular tachyarrhythmias, and there will be surgical stress response of the patient, and there will be earlier recovery when compared with GA alone. So the extreme application of neuraxial analgesia in this construct is to perform cardiac surgery without general anesthesia. However, Watanabe et al. Published data from a large series of awake patients undergoing off-pump CABG, for which multiple vessels could be grafted through advancements in surgical technique and regional anesthesia. With respect to spinal analgesia for cardiac surgery, a meta-analysis by Zangrillo et al. Found no differences in outcomes, including mortality, perioperative MI, and length of the hospital stay. So here are the recommendations for neuraxial techniques in the setting of full anticoagulation for cardiopulmonary bypass. In setting of neuraxial blocks should be avoided in patient in case of traumatic TAP. Surgery should be delayed neuraxial instrumentation. And when it comes to the heparin timing, systemic heparination should be delayed at least 60 minutes after neuraxial instrumentation. Then coming to the dosing and reversal, administer the smallest dose of heparin for the shortest duration possible as compatible with therapeutic regimes requirements for cardiopulmonary bypass. And when coming to with epidural catheter removal, catheter should be removed only after normal coagulation has been confirmed, and close monitoring for epidural hematoma should be continued. In this, many many anesthesiologists remain hesitant to use these approaches based on some unique considerations in the cardiac surgery, because cardiac surgical population will be on any of the anticoagulant drugs or dual antiplatelets. So, despite growing evidence for the efficacy of neuralgial analgesia, in particular, full heparization generates increased concerns about epidural hematoma and the devastating possibility of paraplegia. So, additional complicating factors like risk of post-CBP coagulopathy and the fact that medical management for many of those patients include antiplatelet therapy. And concurrent aspirin use with systemic heparization is a known risk factor for epidural hematoma after neuraxial instrumentation. So when comes with the actual risk of epidural hematoma in this setting is difficult to assess, but it is a relatively rare event. So when you take the study group from 1966 to 2012, 3 of 16,477 patients who received thoracic epidural analgesia for cardiac surgery suffered catheter-related epidural hematomas. Based on these data, the estimated risk of epidural hematoma is 1 in 5,493 cases. So due to the risk of hematoma formation, due to the risk of hematoma formation, many anesthesiologists who currently place epidural catheters for cardiac surgery remain abundantly cautious. Typical recommendation for initiating systemic heparin regimes after neuraxial instrumentation is to delay at least 1 hour after the procedure. In contrast, considering the full anticoagulation required for cardiopulmonary bypass, many anesthesiologists place epidural catheters the day prior to the surgery and will insist that surgery be delayed at least 24 hours in the event of bloody attempts. This approach to traumatic insertion was published by the American Society of Regional Anesthesia and Pain Medicine in most recent guidelines for regional anesthesia in patients receiving antithrombotic therapy. Meanwhile, the risk of spinal cord injury from hematoma remains somewhat unclear, and the evidence is limited and conflicting for the hemodynamic impacts of neuraxial blockade in these patients. As such, the application of neuraxial analgesia to cardiac surgery remains controversial until more definitive evidences becomes available. Therefore, optimal patient selection is recommended when considering neuraxial techniques, and the risk factors for epidural hematoma. For epidural hematoma and hemodynamic instability must be considered for each patient before pursuing any type of neuraxial blockade. It is also important for anesthesiologists to continue to optimize perioperative regimens, analgesic regimens through application of thoughtful multimodal approaches like using of NSAIDs and sternal blocks. Thank you. And in my experience, I have done 2 cases of awake coronary bypass under thoracic epidural analgesia, where I have placed the epidural catheter 2 hours prior to systemic heparinization. Then, after confirming that there is no bloody tap and no back blood tinge in the epidural catheter, then we have given full local anesthesia till the level is achieved, and we have started the surgery. And after shifting to the ICU, both patients were doing fine, and we are able to mobilize the patients as soon as possible after shifting to the ICU. And we have epidural catheter on the day 1, even though after giving clopidogrel, but no adverse effects have seen after epidural catheter removal. Thank you.
Thank you, Dr. Suresh, for highlighting the issues. Thank you very much. Now, I will ask my faculty professors they have prepared quiz to the audience. So, first I am asking Dr. Vidita, Professor Anesthesiology, to share his slides about this.
Thank you, sir. I'm just sharing my slides.
In the quiz, we'll wait for 10 seconds, and then the answer will be reflected. Okay? Slide format. Make the slide bigger.
Can you see, sir?
I can see, but you make kindly be on the slide here. Presentation.
Yes, yes.
That's okay.
Okay.
It's okay.
Good evening, everyone. Thank you for giving me this opportunity. I would like to ask some questions. Question number 1. Which of the following anticoagulants has the shortest half-life and is thus safer to use in patients undergoing regional anesthesia? The options are warfarin, dabigatran, enoxaparin, and rivaroxaban.
Time started already. 10 seconds.
Okay. And the answer is enoxaparin. Enoxaparin being a low molecular weight heparin, it has a shorter half-life compared to DOACs such as dabigatran and rivaroxaban as well as warfarin. This shorter half-life around 4 hours makes it easier to manage the perioperative bleeding risks. Okay. Can I go to next question, sir?
Yeah, please. Most of them answered the same from the
Oh.
audience.
Okay, sir. The next question. A patient on long-term heparin therapy is scheduled for spinal surgery. What is preferred management strategy for perioperative anticoagulation? Option 1, continue heparin therapy up to the day of the surgery and restart it postoperatively. Option 2, switch to warfarin therapy 5 days before the surgery and check INR before the surgery. Option 3, use a heparin bridging strategy, switching to low molecular weight heparin and stopping close to time of the surgery. And option D, discontinue heparin therapy 24 hours before the surgery and restart low molecular weight heparin postoperatively.
Now the question is open for 10 seconds.
Yeah.
Yeah, you can go ahead with the answer.
And the answer is C, use heparin bridging strategy, switching to low molecular weight heparin and stopping close to the time of the surgery. Heparin has a shorter half-life compared to warfarin, making it suitable for bridging therapy in patients undergoing surgery requiring temporary interruption of anticoagulation.
Go ahead.
Next question. A patient presents for surgery and is on apixaban for deep vein thrombosis, and they plan to perform a lumbar plexus block. And what is the most appropriate action regarding the patient's anticoagulation therapy? Continue the drug as prescribed, as it has minimal impact on regional anesthesia technique. Option B, skip the drug on the morning and resume it postoperatively. Option C, stop the drug to heparin for bridging therapy until the day of surgery. And option D, stop avaxabam 24 hours before surgery and check anti-10A levels before proceeding. Okay. And the answer is D. Stop apixaban 24 hours before surgery and check anti-10A levels before proceeding. This drug, like other DOAs, should ideally be stopped prior to surgery to minimize the risk of bleeding during regional anesthesia. Checking the anti-10A levels helps to ensure the adequate reversal of these anticoagulant effects. And going to the next question. A patient on chronic warfarin therapy is scheduled for elective hip replacement surgery. What is the recommended approach to manage anticoagulation perioperatively? The options are Option A, continue warfarin therapy with a targeted INR of 2.5 to 3.5 throughout the perioperative period. Switch from warfarin to heparin therapy and manage a bridging strategy. Option C, discontinue warfarin 5 days before the surgery and proceed. And option D, check INR on the morning day of surgery. If below 2, proceed with surgery without additional interventions. And the answer is option B, switch from warfarin to heparin therapy and manage it with a bridging strategy. Warfarin should typically be discontinued before surgery to allow INR normalization, and bridging therapy with heparin is often used to maintain anticoagulation until the procedure. It reduces the bleeding risk associated with the long-term warfarin use. And going to the next question. A patient on dabigatran for atrial fibrillation requires an urgent craniotomy. What is the most appropriate management strategy for perioperative anticoagulation? Option A, discontinue dabigatran 24 hours before the surgery and check thrombin time before proceeding. Switch dabigatran to heparin therapy and manage with a bridging strategy. Continue dabigatran until the morning of surgery and restart it postoperatively. And option D, administer idarucizumab before surgery to reverse dabigatran's anticoagulant effects. And the answer is option D, administer idarucizumab before surgery to reverse dabigatran's anticoagulation effect. It is a specific reversal agent for dabigatran and should be administered in urgent surgeries to rapidly reverse its anticoagulation effects. Going to the next question. Which of the following anticoagulants has the shortest onset of action and can be managed with minimal interruption before surgery? Option A, warfarin. Option B, enoxaparin. Option C, dabigatran. And option D, rivaroxaban.
Out of 4, which is the shortest acting?
Shortest onset of action and can
Yeah,
be
shortest.
Yes.
Shortest onset of action. Out of 4.
And the answer is option D, rivaroxaban. It has a relatively quick onset of action, which allows for shorter interruption periods before surgeries compared to other anticoagulants like warfarin. And going to the next question. Which of the following laboratory tests is most useful in assessing the adequacy of anticoagulation reversal of DOSs before performing a regional anesthesia? Option A, PT-INR. Option B, activated clotting time. Option C, thrombin time. And option D, anti-10A levels. The answer is anti-10A levels, option D. These are specific assays used to monitor and assess the adequacy of anticoagulation reversal for patients on DOSs before proceeding with any regional anesthesia or surgery. Going to the next question. Which of the following laboratory tests is most commonly used to monitor the effects of unfractionated heparin therapy in patients undergoing regional anesthesia? Option A, anti-10A levels. Option B, PT-INR. Option C, APTT. And option D, thrombin time. To monitor the effects of unfractionated heparin.
The short acting.
And the answer is APTT. APTT is the standard laboratory test used to monitor and adjust unfractionated heparin therapy in patients undergoing regional anesthesia. And next question. Which of the following anticoagulants has the highest risk of causing spinal hematoma when used in patients undergoing neuraxial anesthesia? Option A, warfarin. Option B, enoxaparin. Option C, rivaroxaban. And option D, unfractionated heparin. And the answer is rivaroxaban. It has been associated with higher risk of spinal hematoma when used in patients undergoing neuraxial anesthesia due to its pharmacokinetic properties and the direct factor of 10A inhibition. Next question. A patient with a history of heparin-induced thrombocytopenia, presents for elective total knee replacement, which is the most appropriate perioperative anticoagulant strategy. Option A, continue heparin therapy with close monitoring of platelet counts. Switch to argatroban for perioperative anticoagulation. Used fondaxipironics as an alternative to heparin therapy, and discontinue anticoagulant therapy and manage with mechanical prophylaxis only. And the answer is option C. This being a synthetic factor 10A inhibitor, that can be used as an alternative anticoagulant in patients with HIT, as it does not cross-react with HIT antibodies. Next question. Which of the following statements regarding the management of anticoagulation in patients undergoing neuraxial anesthesia is correct? Option A, more than 5,000 units of heparin should be discontinued at least 4 hours before neuraxial anesthesia. Low molecular weight heparins can be resumed 6 hours after epidural catheter removal. Direct oral anticoagulants require longer interruption periods compared to warfarin before the neuraxial procedures. And option D, platelet transfusion is recommended before neuraxial anesthesia in patients on antiplatelet therapy. Which of the following statements is correct? And the answer is option B, low molecular weight heparins, as they have a shorter half-life compared to unfractionated heparin, allowing them to be safely resumed 6 hours after removal of any epidural catheter. Next question. Which of the following anticoagulants primarily inhibits thrombin factor 2A in the coagulation cascade? Option A, warfarin. Option B, heparin. Option C, dabigatran. And option D, rivaroxaban. And the answer is dabigatran. It is a direct thrombin inhibitor that specifically targets and inhibits thrombin factor 2A in the coagulation cascade. Next question. Which of the following statements regarding the mechanism of action of warfarin is correct? Warfarin directly inhibits factor 10A, thereby preventing thrombin formation. Option B, warfarin acts by inhibiting vitamin K epoxide reductase, thus reducing the synthesis of vitamin K-dependent clotting factors. Option C, warfarin enhances the activity of antithrombin 3, leading to inhibition of thrombin activity. And option D, warfarin binds to antithrombin 3 and forms a complex that inactivates thrombin. And the answer is B. It acts by inhibiting vitamin K epoxide reductase, thus reducing the synthesis of vitamin K-dependent clotting factors.
Thank you, Dr.
Thank
Vivita.
you.
Now I will invite
Thank
Dr.
you.
Lakshmi Priyanka to share his slides regarding the clear slides.
Thank you, Viresham sir.
Kindly share the slide.
Yes, sir. Just a moment, sir.
Is there any problem?
Yes, sir.
What happened? Do you need help, kya?
No, ma'am, I'm getting it. Just a moment.
Otherwise, meanwhile, we can handle questions also, no problem.
Yeah.
I got it, ma'am. Is my screen visible, ma'am?
Yeah.
So there goes my first question. Which of the following agents are not used as possible reversal agents for warfarin in emergencies? Option A, prothrombin complex concentrates. Option B, fresh frozen plasma. Option C, vitamin K. And option D, protamine.
So many people answer D.
Yes, answer is D, protamine, because prothrombin complex concentrates are rich in vitamin D dependent factors like 2, 7, 9, and 10, whereas FFP is also rich in coagulation factors. But protamine is a reversal agent used for heparin.
Good.
The next question. The superficial nerve blocks can be performed in patients with INR of more than 1.5 with minimal safety concerns. Which of the following is not considered a superficial nerve block according to literature? Erector spinae plane block, B, femoral nerve block, C, infraclavicular brachial plexus block, D, saphenous nerve block.
– 30 to 40% they are answering D.
No. According to the reference quoted below, the superficial nerve blocks are erector spinae plane block, interscalene block, brachial plexus block, superficial brachial plexus block, femoral nerve blocks, distal sciatic popliteal nerve blocks, saphenous nerve blocks, and foot and ankle blocks. Whereas deep nerve blocks, wherein INR should be less than 1.5, are deep cervical plexus blocks, stellate ganglion blocks, infraclavicular brachial plexus blocks, psoas compartment blocks, lumbar blocks, proximal sciatic blocks, spinal anesthesia, and epidural anesthesia. All these are considered deep blocks, wherein the INR should be less than 1.5, and the reference is quoted below. So according to this question, the answer is C, wherein the INR has to be less than 1.5 for giving this block. That is infraclavicular brachial plexus block. Third question is, all of the following are intravenous antiplatelet agents except A, tirofiban, B, clopidogrel, C, eptifibatide, and D, apixaban. Yes, the answer is B, clopidogrel. The rest are intravenous antiplatelet agents. Even cangrelor is also an intravenous antiplatelet agent. Fourth question. Which of the following is a reversible ADP receptor antagonist? A, ticlopidine, B, ticagrelor, C, prasugrel, and D, clopidogrel.
Reversible.
The answer is yes. The answer is B, ticagrelor. Ticagrelor and cangrelor are reversible ADP receptor antagonists. The problem with them is when you freshly transfuse platelets to reverse them, they might immediately block the soluble ticagrelor may immediately block the freshly transfused platelets. So the platelet transfusion might be less efficient for up to 24 hours after last intake of ticagrelor. Next question is the disadvantages of direct acting oral anticoagulants over warfarin. The most preferred option. You have to select the most preferred option. A, shorter t-half. B, better safety profile and predictable pharmacokinetics. C, routine lab monitoring of anticoagulant is not required. And D, no specific antidote. Yes, the answer is D.
No specific.
Unlike warfarin, warfarin has antidote, that is vitamin K can be given. But the newer direct-acting oral anticoagulants, they're still under research. Idarizumab is the only approved antidote for dabigatran, but the other reversal agents are still under development. The next question, which anticoagulant exerts its effect by binding to antithrombin 3 and potentiating its inhibition of factor 10A? A, heparin, B, dabigatran, C, rivaroxaban, D, fondaparinux. Yes, the answer is heparin. How does, seventh question, how does rivaroxaban exert its anticoagulant effect? A, by inhibiting vitamin K epoxide reductase. B, by directly inhibiting factor 10A. C, by directly inhibiting thrombin. And D, by binding to antithrombin 3 and potentiating its activity. Yes, the answer is B, by directly inhibiting factor 10A. All these are factor 10A inhibitors. Next, the eighth question. What is the recommended anticoagulant for pregnant women as a part of DVT prophylaxis? A, warfarin, B, low molecular weight heparin, and C, direct-acting oral anticoagulants. Yes, the answer is a low molecular weight heparin. Yes, sir, I'm done with my question.
Okay. Thank you. Thank you, Lakshmi Priyanka.
Thank you, sir.
Now we will answer the questions which are in the chat box, and the questions. Now the topic is open for discussion with the help of coordinators of National ISA.
Thank you, sir. Dr. Anu, can you just see the questions in the chat box?
Yes, ma'am.
all the questions which are not addressed, we can just answer those
Okay.
questions. Okay.
They have written answers in the chat box itself, ma'am.
Yeah, only those which are not answered.
Because of the
I
options here.
Scroll down. Just scroll
Yeah.
down, na? You'll get
Huh.
questions.
Yeah. There is one question regarding IV fluids, I think, which can be discussed, sir.
We
have given regarding IV fluids.
Yes, ma'am.
Kirisha,
Yeah.
I
Yes,
told you
sir.
no, that regarding the IV fluid,
Yes, sir.
plasma
So,
expanders and anticoagulants, you can tell.
yes, sir. So for in this patient, we did not. We have given the we have given the IV fluids according to the Holidays Segar formula, sir. We have followed the 4-to-1 rule. We were targeting a urine output of around 1 ml per kg per hour in this patient. Since there was no cardiac compromise, his ejection fraction was maintained, and also his urine output was also good before the surgery. Intraoperatively also, we were maintaining a urine output of 1 ml per kg per hour. And we did not encounter any major hemodynamic instability during the surgery, sir, intraoperatively. So we luckily we did not use any plasma expanders, or blood was not required. The blood loss was also minimal intraoperatively. It was only around 150 ml.
Okay, it's all right. But if you happen to use this plasma expander, how it interfaces with the anticoagulant?
So, sir, in case if we encounter any major hemodynamic instability, we will intraoperatively we would like to use plasma expanders like Hemasil, sir. In this in the Hemasil, until usually if the patient is losing a lot of blood and we are having a hemodynamic instability, at that in that case we can use Hemasil to just wait until the blood comes, so that we will hold the pressures until then. So, but
How many hours it will
preoperatively,
maintain? Will they
sir,
interfere with the anticoagulant? They increase the bleeding?
not aware.
Not aware. What about Nitish?
Sir?
Nitish,
Sir. Tell me, sir.
plasma expanders. I told you to plasma expanders and anticoagulant drugs. Naturally, they will interfere with the coagulation system. So there may be a chance of increasing their bleeding tendency. And this will add to our anticoagulant. That is why we should be careful about giving plasma expanders when the crisis happens. Better try to avoid those plasma expanders and try to secure the fresh blood. It will have all anticoagulants, whatever is required. And if you diagnose one particular factor is deficient, you can plan for that particular factor and then a transfer.
Yes, sir, I agree with you, sir. Blood products is always preferable compared to any plasma expanders or IV fluids if we feel there is any requirement.
Better you go with the
Yes.
IV fluids, normal IV fluids, single lactate or normal plasmolite, all whatever the electrolytes it is having, it's plain IV fluid. And, better to avoid plasma expanders, those who are anticoagulants.
Yes,
That is
sir.
the concept. Any difference of opinion from the faculty of participating faculty?
So most of the questions have been answered
Yeah.
by Dr. Priyanka in the chat box. So if anybody wants to ask any questions.
There is a question, ma'am. Is heparin or low molecular weight heparin, which one can be used for bridging therapy?
Heparin is used usually for bridging therapy. I have answered that in the chat box, I think, Nisha.
Yes. Answered.
Okay.
No more questions, sir.
Thank you, madam. This is one
There
more
is a
thing.
one question, I think, which Sirisha was answering. Sirisha, as a postgraduate, I think you did a wonderful job in answering the things yourself, rather than taking the help of the moderators. And I think the PG classes are coming of ages now. The PGs are getting more confidence in answering to the general audience. That is what is required, actually. I don't require the moderators to be answering everything. If you're your third year, second year, if you are having knowledge, you should be answering. There was a one question which was asked to you about the level of which you achieved at T6.
Yes.
Whether the hemodynamic instability, that was a little bit of incomplete answer you gave.
Okay.
Other here, you should have answered that because T6 or T8, there is a hardly much difference of hemodynamic instability, provided you
Yes.
involve the cardiac accelerator fibers from T2 to 3, 3, 4, 5, 6. Once they
Yes.
are involved, then it becomes almost grossly unstable hemodynamics, and you will not be able to control once the cardiac accelerator fibers are inhibited. So that should have been answered there. Otherwise, you presented well and answered well, and same goes for Nitish also. Nitish is becoming more of a veteran now in the presentation, and I know he will be doing this justice to Dehradun also if he comes. So I don't know whether he's coming or not. So it's a good attempt by the PG student and the senior resident, and well trained by the class coordinators, moderators, and Dr. Viresham, the HOD. I think almost everything is answered. There is nothing left. I can see Dr. Tejkal sitting and want to speak, sir. Call, sir. You can unmute yourself. Good evening, sir. You want to just add
Very
your
good evening to everybody.
Good evening, sir.
Very good evening to everybody.
Good evening, sir.
It's a great
Thank you, sir.
pleasure. Dr. Bajwa, it's a great pleasure to attend and watch these PG classes. The excellent performance by the PG residents under your guidance and the moderators. It is not only an knowledge transferring to the residents. I may say, and I must admit, that this knowledge transfer is equally important for the seniors. Even I have learned a lot about it. I must compliment Dr. Bajwa and all the speakers and their mentors and their moderators. The MCQ type of questions which was done at the end was really remarkable, a refreshing exercise to revise your subject. I thank you once again, and hats off to Dr. Bajwa for introducing such things in ISA. God bless you, the speakers, the moderators, everybody, and God bless ISA. Thank you.
Thank you, sir. You have always been a very encouraging force, not in ISA, as a personal level also, and we always look towards you when we require any help or guidance. You are a true mentor of us, and as a teacher of teachers, we really salute your knowledge and your participation in these classes. It's a wonderful experience for us also. And before anybody takes up another question, I just like to just wait. My screen visible?
Yeah.
Yeah. So regarding this, it was a comprehensive class. I took. It doesn't matter. It takes almost 2 hours. But regional anesthesia anticoagulation is a big chapter. If you go globally,
More
wherever.
than 2 hours. More than 2 hours.
Sir, it's not possible to finish even in 5 hours if we really go with the regional anesthesia.
No, it is perfectly okay. I have enjoyed it. I have enjoyed it.
It was an
I
enjoyable
don't know
class.
about others, but I have enjoyed and I have attended right from the beginning to the end.
Yeah. And we thank the team leader, Dr. Viresham. Sir, he has done a wonderful job in preparing his team and taking initiative also to present this class.
Thank you, sir.
And Dr. Vidita and Dr. Priyanka both did a wonderful job because I just told them to prepare the MCQs and they prepared in abundance, revised the entire syllabus at the end of the chapter. I think now whosoever is going to watch this class on the YouTube, they will be able to answer almost everything in the Viva of the practical final examination of postgraduate third year.
Thank you, sir.
So,
Thank you so much.
Dr. Vidita and Dr.
Thank you,
Priyanka,
sir.
thank you very much.
Thank you
Thank
so
you.
much for giving us this opportunity, sir. Thank you so much.
And equally thanks to Dr. Suresh Kumar also, the way he brought up, because being a cardiac anesthetist, getting involved, it becomes almost, a comprehensive coverage of almost every aspect of regional anesthesia and anticoagulant. Thank you, Dr. Suresh, for
Thank you
being
very
with
much,
us
sir.
today.
Thank you, sir.
And Nitish, as always, usual, I know him very well now. Nitish and Sirisha was excellent today. As a
Thank you, sir.
Thank you, sir.
PG
Thank you,
student,
sir.
she answered. I like the attitude of answering to the general audience without any hitch. That was a good way.
Thank you, sir.
Thank
And
you, sir.
Anusha and both Manaswini, they being from the same institution, they like to be the coordinators. So we really thank to both of them to being a part of this class. So it's a wonderful experience for the entire Kaminin Institute of Medical Sciences. They've done a wonderful job today. And we really thank ISA National as a whole, thanks to this team. And they have covered this class and it will be available on YouTube after this class is over. So anybody can watch this class and it will go a long way in helping the PG student to learn the ins and outs of regional anesthesia and anticoagulation. Almost only one thing I want to add here. Depending upon ISRA, ASRA, so many guidelines, why not having ISRA, ISARA guidelines?
Yeah, yeah.
Should be having those guidelines. And I started that concept, but it, got diluted somewhere in between. As a secretary, you cannot take the entire job of the academics, the administrative jobs. So it was there. I think gave birth to this concept 1 year back, but somehow it got diluted. Today, after this class, it has rejuvenated, re-invited, and I think we will go for the ISRA guidelines in the regional anesthesia.
Sir. If that ISRA guidelines come, please give me the opportunity to present the class, same ISRA as well.
Yeah, you present it to world class, global level. We will be formulating it and a team will be formed very soon. We will get it passed in the upcoming GC meeting also. Once the approval is there, formally approval has to be taken from the governing council. Once taken, we will go for the ISRA guidelines in our own setting. I think 1 year will be taking for the development, grinding, collecting evidence and everything and experiences and the literature from our own Indian patients. They will be truly ISRA guidelines and will be helping each and every anesthesiologist, the PG students, the practitioners, as well as the academicians.
In the end, can I say something?
Yeah, you always, sir, you're always welcome to say something.
Actually, whatever the guidelines are there in this anesthesiologist clinical experience with the patient is very, very important. This is the message I wanted to give. So be in touch with the anesthesia practice and do things as per the guidelines. And if complications are there, then report. That is very important for the development of better guidelines. Thank you, sir.
And I will tell you now why the ISRA guidelines are important. Because it's a tropical country with a varied culture. If you travel from north to south or east to west, you will get a variable cultural practices, the food practices, and the alternative therapies available in India. So many homeopathic, Ayurvedic, Unani, so many medicines are there. They are interfering with the coagulation process, which has not been touched, I think, properly. They interfere with the coagulation process in such a manner that you will never get an evidence how much it is going to impact, because nobody takes a history in the pre-anesthetic evaluation that what alternative therapies. No, you will always ask anything for the, all the systemic diseases you have seen in your life, but nobody says, have you ever taken the Unani medicine, Patanjali medicine, Ayurvedic medicine? Nobody will get a history and nobody will take. But these really impact the coagulation process, whether you go for a 10A level, whether you go for the APTT or you go for the PTINR, everything is impacted. You go to the alternative therapy and anesthesia. These are very, very important. And I was talking about the 1 in 5 patients taking the anticoagulants. I'm talking is 1 in 3 patients must be taking these alternative therapies in India.
Exactly.
Every almost second adult in any
Very
family, in any state, will be taking these things, and they really impact when these patients present for. They will never give you history that whatever medicine we are taking. So these are the things I think that prompted me to think over the ISRA guidelines, because nowhere in the world so much of the alternative therapy is used as much as is used in India. And these are the very confounding studies, factors, which impacts the outcome of these regional anesthesia and anticoagulation. I think if we we collect our literature sincerely from these patients, we may come out with something very unique and profoundly impacting the global guidelines also. So
Yes.
that's what the idea of ISRA guidelines, which I was born 1 year earlier.
Thank you, sir. Thank you, sir. We are with you.
Yes, sir.
So anybody wants to add to this thing, or to this class especially? I think everybody has complimented the speakers and the moderators today. So it's a very well presented class, and it will be Nitish and Sirisha will be very happy to see themselves on the YouTube channel again and again by the people,
Definitely.
You have given that opportunity.
Yes, sir. All credits to you.
Thank you, sir.
So I think it's 8:45. We should end this class. I think it's time now to say goodbye.
Thank you.
Yes, sir.
ISA.
Long live ISA.
Long, yeah.
live
This is the first time people saying
you.
before me.
Thank
Yeah,
you,
long
Dr.
live
Bhagwat.
ISA.
Long live ISA.
Long live ISA.
Jai ISA.
Yeah.
Thank you.
Long live
Thank you,
ISA.
sir.
Long
Thank
live
you so much. Thank
Thank
you.
you. Thank you so much.
This opportunity.
Thank you, sir.
Good night, sir. Good night, everyone.